Hello, 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 ladies and gentlemen. Good morning. And today we are talking about the post-op patient, the surgical patient. So, class outcomes for this class, we will explain the concept of perioperative nursing care. We will differentiate between the different classifications of surgery, describe the nursing assessment data to collect for a surgical patient, discuss the nurse's role in the patient's pre-surgery preparation, preoperative teaching, and administration of preoperative medication, and then describe the various types of functions and effects of anesthesia and perioperative medications on the surgical patient, and then the nursing implications. We will differentiate between the various roles of the nurse in the operating room. We will discuss the specific nursing assessments and interventions used to prevent and or treat post-operative communications. We will develop a post-operative teaching plan because we are nurses, and essential education for the post-operative surgical patient. And because we are nurses, we are going to apply the nursing process to the perioperative patient. So, perioperative nursing involves the care of clients before, during, and after the surgery and other invasive procedures. So, historically, perioperative nursing practice was called operating room nursing, and it was limited to transferring patients into and out of operating rooms and handing instruments to the surgeons during the surgical procedure. Nurses in all phases of the operative experience now actively provide and manage care, teach, and study the care of perioperative patients. So, the Association of Perioperative Registered Nurses is a highly organized and influential specialty organization within the nursing profession. And they have developed guidelines for perioperative practice. These were developed in 2009. They were revised in 2020. And these are to keep perioperative nurses up to date on care practices. So, an important aspect of perioperative nursing is to help prevent complications of surgery. Hand hygiene is an important component of prevention, and preventable perioperative errors can cause surgery-related deaths. They can have an unfavorable financial impact on healthcare institutions and result in physical and emotional harm to patients. So, various government and private organizations, including the following, will stress the importance of patient safety. And so, perioperative safety is one of the three domains under which ORN organizations its perioperative patient outcomes. Specific safety outcomes include prevention of injury and freedom from infection. The Joint Commission back in 2020 developed patient safety goals applicable to surgery, including preventing safety, improving the accuracy of patient identification using medication safety, and performing a timeout immediately before starting procedures. So, the National Quality Partners Leadership Consortium in 2020 established a national priority that would include the aims of achieving better care, providing improved health for people and committees, and making quality care more affordable. The Institute of Healthcare Improvement in 2011. This is an independent, not-for-profit organization that will work to reduce morbidity and death in American healthcare, including perioperative healthcare. So, ladies and gentlemen, listen up, and then listen up one more time. Preoperative care. The preoperative phase will begin with the client's decision to have surgery and ends when they enter the operating room. The length of the preoperative period and the extent of the patient teaching will depend on the type of surgery and the patient's overall health status. So, nursing care during the preoperative phase will focus on identifying existing health concerns, planning for intraoperative and postoperative needs, and providing preoperative teaching. Preoperative nursing care is delivered in a variety of settings. More than 2/3 of surgeries in the United States are performed in outpatient settings, such as the endoscopy suite and ambulatory care centers. So the perioperative nursing data set is a standardized vocabulary specifically designed to describe the care of perioperative patients, and it is recognized by the American Nurses Association. The latest update of PNDS reflects the nursing process, including nursing assessment, diagnoses, identified nursing sensitive outcomes, nursing interventions, and implementation and evaluation. The PNDS will promote better communication among nurses and other healthcare providers, increase visibility of nursing interventions, improve patient care, and standardizes a way to evaluate nursing care outcomes. So, for patient safety, data must be correct and complete. So, to prevent omission of important information, most organizations will have developed a preoperative checklist. So, it is essential to determine whether the client is physiologically, cognitively, and psychologically prepared for the intraoperative and postoperative phase of surgery. So, for a complete and accurate nursing history, we will collect assessment data from the client and significant others, whoever lives with the patient, medical records, and other members of the healthcare team. So, ladies and gentlemen, listen up, and then listen up one more time. The focused nursing history will include topics. These topics are the health history, the physical status, allergies, medications, and this includes all medications, prescription medications, vitamins, minerals, supplements that I'm taking, and anything that I am taking over the counter. My mental status, knowledge and understanding of the surgery and anesthesia, and then culture and spiritual factors. Ladies and gentlemen, please take note of this slide. So the focused nursing history will also include access to social resources, coping strategies, substance use, for example, alcohol, tobacco, recreational drugs. It is also important to elicit patients' values and expressed needs. Additional assessments may be needed if the client is undergoing outpatient surgery or if he has a planned short stay after the surgery. If the nurse identifies risk factors from the nursing history, we will focus on those aspects during the head-to-toe physical assessment. So, for example, if the patient states they had a cough last week, I am going to perform a focused assessment on the ear, nose, throat, and lungs to determine how the cough may affect the patient's risk for surgery. Ladies and gentlemen, listen up, and then listen up one more time. If the patient has lower airway congestion, as I am assessing their lungs, and I note this, there will be abnormal breath sounds and a productive cough. I have to communicate these findings to the surgeon and the anesthesia team, as the patient may have an infection. So if a general anesthesia is planned, it may be necessary to delay the surgery. So for all patients, I will assess risk factors for thrombophlebitis. Thrombophlebitis is a fancy name for inflammation that will result from a blood clot in a vessel. And then a venous thrombus, same thing, it's a blood clot, is one of the complications that is important to prevent. Ladies and gentlemen, please take note of this slide. So, recent guidelines will state that optimal preoperative assessment of older adults will include the following: cognitive ability, capacity to understand the surgery, nutritional status, risk factors for post-operative delirium and pulmonary complications, and then the patient's treatment goals and expectations. Family and social support system, depression, cardiac status, functional status, if there is any history of falls, and then a detailed medication history, including polypharmacy. We will also note a baseline frailty score and diagnostic tests specific to older patients. So, individualized nursing diagnoses. Individualized nursing diagnoses for the preoperative patient will evolve from the assessment. The nurse should identify an actual nursing diagnosis only if the patient has the defining characteristics for it. So, we will identify risk, meaning potential diagnosis, only if the patient has an underlying condition that will place them at higher risk than the average surgical patient. So, the following nursing diagnoses may be useful for certain preoperative patients. Anxiety. Anxiety may be mild, moderate, severe, or my patient may be at panic level. Make this diagnosis only if the client has symptoms such as restlessness, trembling, increased pulse, and other defining characteristics. Fear. Fear is a common reaction to surgery, so use this nursing diagnosis only if more than routine interventions are needed. Airway clearance impairment. This may be used for patients who have a pre-existing health problem, such as bronchitis. Disturbed sleep pattern often results from anxiety about the upcoming surgery. Ineffective coping. This may be appropriate for a patient with extreme anxiety and concern about the outcomes of their surgery. And then a latex allergy reaction. This is appropriate for patients who have a known allergy to latex. Now, ladies and gentlemen, listen up, and then listen up one more time. The nursing diagnosis of risk for allergy reaction to latex is appropriate for patients who have had multiple surgeries, multiple urinary catheterizations, or they are in a profession with daily exposure to latex, or if they have a history of asthma, or they are allergic to bananas, avocado, kiwi, chestnuts, or the poinsettia plant. So we're not going to use this routinely for all patients. So if patients have a pre-existing allergy to any of these items, the banana, the avocado, they are going to have a higher risk for a latex allergy. So we need to be aware of this. Please take note of this slide. Please continue to listen up, ladies and gentlemen. The surgical consent. Before a surgical procedure is performed, professional standards and the law will require the surgeon to obtain the patient's informed consent. So the signed consent form will verify that the surgeon and the patient have communicated adequately about the surgery. Once this consent form is signed and witnessed, the consent form is part of the patient's record and it will accompany them to the operating room. Ladies and gentlemen, please take note of this slide. Ladies and gentlemen, please continue to listen up. The surgeon is responsible for 1, giving the patient the necessary information, and 2, determining the patient's competence to make an informed decision about the surgery. The nurse is only responsible for verifying that the surgical consent is signed and witnessed. Please take note of this slide. So a surgical consent form will include the following information, according to the Joint Commission way back in 2010. The type of surgery that is being performed, the surgeon needs to note that. He also needs to note his name and his credentials, and the primary practitioner for the patient's care and treatment post-surgery, a statement that will explain the risk and the benefit of the surgery, as well as reasonable alternatives, and he will note that all of this has been explained to the patient. So a statement of the relevant risks, benefits, and side effects of the alternatives, the likelihood of achieving goals, a statement that the patient has the right to refuse surgery or withdraw consent at any time. When indicated, any limitations on the confidentiality of information about the patient. So obtaining the signature. Often the nurse will obtain the patient's signature and document on the preoperative checklist that this was done. As a patient advocate, the nurse should verify. First, I am going to verify with the patient that the physician has explained the procedure and answered all of their questions. And I will ask the patient to state what they were told during the consent process. I will notify and delay, if necessary, if the patient has questions or if the nurse has any questions about the patient's competence. I will notify the surgeon and delay sending the patient to the operating suite. And then I will document. Be sure to document these conversations and document in the nursing notes that the surgeon was notified of any additional questions or concerns. And then informed consent. A signature on a form will imply consent. The nurse must be certain that the signature represents informed consent. So there are two important requirements. The patient must be alert, rational, mentally competent. They must not be sedated when they sign. The information must be given to them in a language and vocabulary that they can understand. Ladies and gentlemen, listen up, and then listen up one more time. Patients who are unconscious or have a cognitive impairment, who cannot read, write, or hear, or those under the influence of sedative drugs or alcohol are not competent to give consent. In most states, a family member, a conservator, or a legal guardian may give consent for the procedure. Informed consent helps protect the patients from having a surgery that they do not understand or that they do not want. Ladies and gentlemen, please take note of this slide. Ladies and gentlemen, please continue to listen up. The signed document will protect the healthcare agency and workers from later claims that the patient did not consent to have the procedure. So informed consent requires that the patient understood the communication and he was not coerced. Coerced meaning pressured to sign the consent form. I am going to provide preoperative teaching. Preoperative teaching will prepare the client for the surgical experience. It will allay some of their fears and it may decrease the risk of post-operative communications. So what am I going to teach? The content of the teaching plan should focus on what will happen before, during, and after surgery, how the patient or the caregiver can participate in the care, common feelings and concerns that patients have about the surgery. This will help the patient to feel supported and they may feel less anxious, and what patients and families can do to prevent surgical site infections. I can talk about the type of surgery that will influence the content of my teaching. For example, if the patient is scheduled for an outpatient knee arthroscopy, arthroscopy is when doctor makes an incision into the knee or in the side of the knee and he actually goes in to visualize the joint. And if this is going to happen under spinal anesthesia, The teaching plan will need to describe the procedure and the anticipated discharge of the patient within hours after surgery. Many times this is done as an outpatient procedure, and the patient stays with us for a couple of hours and then they go home. This is very different from the teaching plan for a patient who will have cardiac surgery, and he is going to spend a bit of time, a number of days in the hospital. So in general, preoperative teaching should focus on what will happen before, during, and then after the surgery. So ladies and gentlemen, listen up, and then listen up one more time. The following safety measures will help to prevent patient misidentification and wrong site surgery. So I am going to use a preoperative checklist to confirm the appropriate documents are available and the appropriate activities have been performed. I will verify the patient's identity before the patient leaves the preoperative area. Ladies and gentlemen, please take note of this slide. And please continue to listen up and listen up. We are going to mark the surgical site before surgery. I am going to use a permanent marker that will not be removed by any of the skin prep that they are going to use in the operating suite. And I will involve the patient in the marking process. And I will make sure that I participate in a timeout. So the surgeon will take a timeout with all of the team members before starting the procedure. Ladies and gentlemen, please take note of this slide. Now let's talk about the operative team. The operative team. The personnel who attend to the client during the surgical procedure are called the intraoperative team. The team is divided into members who must use sterile technique and those who will use clean technique. So during the intraoperative phase, a registered nurse can function as the scrub nurse, the circulating nurse, or the RN first assistant. Each of these roles will contribute to the safe care of surgical patients. Members of the sterile intraoperative team will include the surgeon, the surgical assistant, and the scrub person. So before beginning the surgery, they will perform a surgical scrub of the hands and the arms. They will dry with sterile towels, and then they are going to gown and glove. The scrub nurse can be an RN, it can be an LPN, an LVN, or it can be what we call a surgical tech. The scrub nurse will set up the sterile field, prepare the surgical instruments, assist with the sterile draping of the patient, anticipate and respond to the surgeon's needs, and maintain the integrity of the sterile field. A registered nurse first assistant is an RN with additional education and training in the surgical techniques. The RN first assistant serves as an assistant to the surgeon, a role that has been historically been filled by other physicians. Sterile team members are the only persons that are allowed to enter the sterile field. Now, the clean team. Team members who will abide by clean technique, and we call this medical asepsis, will include the anesthesiologist or the nurse anesthetist, the circulating RN, biomedical tech, or radiology technicians. These personnel will never enter the sterile field, but then instead they will function around and beyond the field. So the sterile field is where the surgeon is, where the patient is, and everything surrounding the surgeon and the patient. These, the clean team, are the outliers. They are going to be outside the sterile field. They do not enter the sterile field. So either an anesthesiologist or a nurse anesthetist will induce the amnesia, analgesia, and muscle relaxation or paralysis with anesthesia. Ladies and gentlemen, listen up, and then listen up one more time. The circulating nurse is an RN, could be any staff RN, who applies the nursing process, because the nursing process does not stop. Everywhere in the building, wherever you are a nurse, it is not going to stop. So she is going to apply the nursing process to coordinate all the activities in the operating room. This nurse is going to be the client advocate who will continuously monitor the client and she is going to monitor the sterile field. The circulating nurse will maintain a safe, comfortable environment, will communicate with appropriate personnel outside of the operating room, and respond to emergencies. So, an important aspect of the circulating nurse's role is to attend to the patient during the induction of anesthesia. Ladies and gentlemen, please take note of the information on this slide. So, the different types of anesthesia. During surgery, anesthesia is used to obtain analgesia, which is control of pain, muscle relaxation or paralysis, and then amnesia. Amnesia is memory loss. So anesthesia can be classified as general, conscious sedation, or regional. So general anesthesia will produce rapid unconsciousness and loss of sensation. The anesthesiologist or the nurse anesthetist will administer inhaled and IV medications that will depress the patient's central nervous system and then relax the musculature. Muscle relaxants, paralyzing agents, narcotics, barbiturates, and inhaled gases are some of the agents that can be used during general anesthesia. The patient will be unconscious, so they cannot experience any anxiety that might affect cardiac and respiratory functioning. The muscles will be relaxed so the patient remains completely motionless during the surgical procedure. Anesthesia can be adjusted to accommodate age, physical condition, and the length of the procedure. So if complications occur, the anesthesia can be continued for longer than originally planned. Some of the disadvantages of general anesthesia: the respiratory and circulatory muscles are depressed, so mechanical ventilation is needed while the patient is under the effects of the anesthetic agent. General anesthesia will create a risk for death, heart attack, stroke, and malignant hyperthermia. Malignant hypothermia is a rare, often fatal metabolic condition that can occur during the use of muscle relaxants and then inhalation anesthesia. Frequent minor complications after general anesthesia will include a sore throat, and this is from the intubation, nausea and vomiting, and this is from the relaxation of the GI smooth muscle, and it's also from the medications that we give you. Headache, uncontrollable shivering, and confusion. Ladies and gentlemen, listen up, and then listen up one more time as we talk about conscious sedation. Conscious sedation will provide IV sedation and analgesia without producing unconsciousness. During conscious sedation, the patient may feel sleepy, but they are aware of their surroundings. They can be easily aroused by touch or speech, and they can talk with the surgical team. There is a rapid return to consciousness. Please take note, there is a rapid return to consciousness. Blood pressure, heart rate, respiratory rate, and oxygenation saturation are monitored, and the patient receives oxygen via nasal cannula during the procedure. Please take note of this slide. Because of the amnesic effect of many of the medications, the patient may not recall aspects of the procedure afterward. Conscious sedation is used for procedures such as bronchoscopy and cosmetic surgeries. Some of the advantages: pain and anxiety are adequately controlled without the risk of general anesthesia, and recovery is rapid. Again, recovery, bringing them out of the anesthesia is very rapid. And one of the disadvantages, well, the patient, this is not practical for a patient that has high anxiety. Regional anesthesia. This will prevent pain by interrupting the nerve impulse to and from the area of the procedure. The patient remains alert, but they are numb to the involved area. Regional anesthesia may be administered by infiltration of the surgical site and surrounding tissue with the local anesthetics such as lidocaine or bupivacaine. These medications may also be injected into and around specific nerves to depress the sensory, motor, and or sympathetic impulses of a limited area of the body. So advantages are that it is low in cost, it is simple to administer, it requires a minimal recovery period, and this is suitable for minor ambulatory procedures. Disadvantages: this may not be practical if the patient is highly anxious or if adequate pain control cannot be achieved. Many patients are apprehensive about being able to see and hear the procedure. So positioning. The position of the patient in the operating room is determined by the surgical site, access to the patient's airway, the need to monitor vital signs, comfort and safety. A position that is ideal for assessing the surgical site may not be used if any of the other factors are compromised. So if the patient has pre-existing injuries or discomfort, we need to factor this information into the decision about how to position. For example, a patient with chronic cervical spine pain may be positioned using a neck roll. The patient is usually positioned after anesthesia has begun. We can use straps, wedges, pillows, and surgical table attachments to maintain the position during the surgery. To prevent shearing, we are going to lift, not slide, the patient into position. Ladies and gentlemen, listen up, and then listen up one more time. The circulating nurse is responsible for presenting what we call positioning injuries. Surgical patients often spend multiple hours in the same position, and this will place them at a risk for pressure ulcer formation. The anesthetic agents will decrease tissue perfusion, and this will further increase the patient's risk for sustaining one of these positioning injuries. So the circulating nurse may need to pad the bony prominences to protect the patient during surgery. So, post-operative care. The post-operative phase will begin when the client enters the post-anesthesia care unit, otherwise known as the PACU, and end when the client has healed from the surgical procedure. This phase will consist of two parts: recovery from anesthesia and recovery from surgery. When the surgical procedure is complete, members of the surgical team will prepare the client for transfer to the PACU, also called the recovery room. The first post-operative phase, also known as the post-anesthesia phase, or the immediate post-operative phase. This phase begins when the patient is transferred from the operating table to a bed or a stretcher for transport to the post-anesthesia care unit. During this phase, the patient is at high risk for respiratory and cardiovascular compromise. As a precaution, the anesthesiologist and the circulating nurse will accompany the patient and attend to any needs during transport. They are also responsible for giving a comprehensive report to the PACU nurse. The PACU, which is located near the operating room, is an open unit that will allow nurses to observe these patients easily. PACU nurses have specialized education and experience in caring for post-operative clients. Nurses working in the PACU will often have experience in critical care. The PACU nurse will receive a comprehensive report from the anesthesia provider and the circulating nurse. Recovery from surgery. Ladies and gentlemen, listen up, and then listen up one more time. The second phase of post-operative care begins when the patient is discharged from the PACU and admitted to the surgical nursing unit. So the patient is transported to the surgical unit only after recovery from anesthesia is evident and the patient is stable. So the goal of this phase is to facilitate healing and prevent post-operative complications. Ladies and gentlemen, please take note of the information on this slide. Please continue, ladies and gentlemen, please continue to listen up. The initial assessment, the PACU nurse will perform a focused initial assessment of the surgical patient in the presence of the anesthesia provider and the circulating nurse. And then there is continued assessment. After that, the PACU nurse will assess the patient every 5 to 15 minutes. Please take note of the information on this slide. Determining recovery from anesthesia, many patients will arrive in the PACU with an artificial airway or an endotracheal tube in place. This patient remains in the PACU, this will remain in place in the PACU unit until the PACU nurse determines that the patient has recovered from the effects of anesthesia and they are able to remove their airway, the artificial airway. The PACU nurse will remove the airway and transfer the patient to the surgical unit. So, ladies and gentlemen, please listen up, and then listen up one more time. The assigned nurse on the surgical unit will admit the patient to the surgical unit. If the patient is transported by stretcher, we are going to then transfer them to their bed. As soon as the patient has arrived, the surgical nurse on that unit is going to perform an assessment and listen to report from the PACU nurse. Please know the information on this slide. The initial postoperative assessment is identical to the assessment that is performed by the PACU nurse. As the patient has undergone a period of stabilization since surgery, the frequency of assessment can be less than in the PACU, where the patient was assessed every 5 to 15 minutes. So the nurse may increase the frequency of the patient's condition as the patient's condition changes. So, ladies and gentlemen, please take note of this slide. Listen up. Agency protocols will vary. However, a common pattern is to assess the patient on arrival to the nursing unit, and then every 15 minutes for the first hour, every 30 minutes for the next 2 hours, every hour for the next 4 hours, and then every 4 hours thereafter. Ladies and gentlemen, please take note of the information on this slide. You're going to want to remember it. Postoperative teaching, ladies and gentlemen, please listen up one more time. Teaching is especially important postoperatively because most patients must perform quite a bit of their own self-care. Postoperative teaching should reinforce content that was taught preoperatively. So to use time efficiently, the nurse should attempt to do some sort of teaching every time I go into the room to perform some bedside care. Be sure the patient is comfortable and alert. Do not attempt teaching when the client is in pain, needs to void, or is drowsy from opioid analgesics. Ladies and gentlemen, please take note of the information on this slide. Incentive spirometry. Incentive spirometry may be prescribed for patients who are at high risk for atelectasis. Atelectasis is the partial collapse or closure of a lung resulting in reduced or absent gas exchange. The lung is just not working. And then pneumonia, sometimes this will happen if the patient has a history of lung problems or smoking, or they will experience a prolonged period of activity. So the incentive spirometer can be prescribed for patients, again, who are at high risk for atelectasis or pneumonia. Incentive spirometry will facilitate deep breathing, increase lung volume, and promote coughing to clear mucus from the respiratory tree. The equipment will vary in appearance, but all devices will include a gauge to monitor the patient's progress in a visual way. So if incentive spirometry is prescribed postoperatively, we will explain its use to the patient. If you know in advance that the patient will be using an incentive spirometer postoperatively, we will include its use in our preoperative teaching. Ladies and gentlemen, thank you for your time and attention. And as always, please reach out with any questions or concerns.